For those of you who don't know me, I'm Anastasia Susie Mahalaju. Most of my colleagues will be pronouncing Susie rather than Dr. Mahalaju because it's a mouthful. So I've come all the way from Australia, and most of you, I think, have come from different parts of the world. So welcome for making the trip here. My position is head of the cardiovascular and hormonal research at the Colling Institute at Royal North Shore Hospital. And I'm the director of the Ambulatory Blood Pressure Service there, as well as a clinical senior lecturer with the University of Sydney. On behalf of the organising committee, it gives me great pleasure to welcome you to our meeting. And in case you're in the wrong room, the 5th International Conference on Clinical and Experimental Cardiology by the Omnics International Group. Thank you for making the trip here today. This conference was initiated with the support
you gotta remember every person
from the editorial board members of the Omnics International Journal of Clinical and Experimental Cardiology, Journal of Cardiovascular.
Dude, what are you doing, man? I already had it set.
And the Diagnostics.
Fuck, man.
Cardiovascular Pharmacology. And open access. Over these 3 days, we are providing this opportunity for sharing your research findings, interacting and encouraging new collaborations, as well as publishing your research in open access journals. Cardiology 2015 aims to bring together large and medium health organisations, directors, academics, scientists and leading scholars to expand and share their experience and research under the theme Blooming Landscapes in Cardio Research, to discuss the practical challenges encountered and the solutions adopted. We welcome you for joining us to witness the advances in the field today. The conference has attracted delegates from around the world, as I mentioned, and who have come from all over the world, and I wish you a pleasant stay in Philadelphia. I'm sure Dr. Sanders will give you some hints, and fruitful discussions at Cardiology 2015. I would like to thank all speakers and their partners for their continuous support and patronage. The Omnics International wishes to thank all the staff of the editorial board organisations who have worked hard to bring this meeting together. Finally, we thank each and every one of you, the participants at this conference. We hope you enjoy the conference and your participation will contribute to new collaborations and research initiatives. And now it gives me great pleasure to introduce our esteemed guests, each of whom will come and take their seat here on the dais immediately following their introduction. And please join me in
everybody grab one.
Welcoming them. I invite Dr. Sammy Louis.
Write your name on side.
Here on the dais.
You got a pen? You got a Sharpie?
Dr. Anthony Martin-Burgess. Sorry if I pronounced your name correctly. We welcome as well. So, Dr. Vladimir Batnatsev. Sorry, Dr. Batnatsev. Dr. Sergey Shushkov.
It's really dark, though.
Is Dr. Shushkov here? No? Okay. And Dr. Sudhakar Akolyaka.
Write your name on side.
Okay. And now request each and every, Dr. Geddes, would you like to take the microphone to give a brief interpretation of what you said, your expectations are for this meeting?
Yes, thank you for the opportunity here to speak today. One of the things I'd like to comment on is the merits of small meetings. I know in my early career, I studied molecular and cellular mechanisms of heart failure. And I remember I mostly went to AHA meetings and I could just stay busy all day nonstop with nothing but, focused stuff on myocytes and molecular and cellular remodeling. And it was at the small meetings that I actually ran out of stuff
found is the device actually can last that long under certain conditions. We also looked at the ones that didn't survive. We had an overall survival of 61%. But there have been a number of cases that didn't survive, and a lot of them didn't survive because they were multi-organ system failure from putting in the device too late. And that's another theme that goes along with cardiogenic shock in general. Treatment has to be aggressive and immediate, or you're going to have patients with kidney failure and brain death and multi-system failure. And that's kind of what happened in most of our death patients. So it has to do with patient selection and timing of insertion. I wanted to show you a few of these, and I apologize for the videos not working, but I want to go through a couple of the cases. And so what you have here is an Impella-assisted right coronary intervention. And this was a 59-year-old man who arrested at home. The EMS people arrived. He was in VF. He was defibrillated. Naturally, he was intubated and brought to the hospital immediately to the cath lab. And you could see up in the right thing, if that showed in a video format, that's all that was left of his right coronary artery. And so the interventionalists went to work, and they were able to open that right coronary up, and you could see the left coronary artery is perfectly normal. I don't know if this works, but let's see. No, it's not working. Nope. Okay. So the left coronary artery is normal. The right coronary artery is stumped. It gets opened up. So the Impella actually wasn't put in at that time. But what ended up happening was he was still sort of in a post-infarct cardiogenic shock state. They had a balloon pump in at the time, but he was still requiring a lot of vasopressors and inotropes. And so we put in the Impella thinking that's all he needed. Well, the problem was he also had aspirated unbeknownst to us. So the Impella was able to support the cardiac output, but it wasn't able to oxygenate him. So we had to actually convert that to an ECMO device. We left the ECMO in. He got through his pneumonia eventually, albeit with a tracheostomy, but that eventually came out, and he was discharged. So this was sort of a good representation of escalation of mechanical support from balloon pump to Impella to ECMO. We like to show that just to show you the power of the technology and how it resulted in a 59-year-old who otherwise would have died. This one is representative of the collaboration with the electrophysiologist. This is an older man, 79 years old, near syncope, VT, and several cancers. And he's going for ablation for his EP procedure. Now, this was an elective procedure. So the Impella device, which you can see with a lot of the other catheters in place, so you'll just have to take my word that one of those many devices in there is the Impella. So that was put in electively before any of the ablation was done. And this was a 4.0 device, and it was very impressive to watch the procedure go on because these things can take hours. And so as hours of VT are going on and they're trying to map the focus of the VT, this patient was so well supported hemodynamically because you have 4 liters per minute of blood flowing through this guy, and they're mapping all over the place and they're burning all the arrhythmias, and yet this guy is absolutely rock stable. And so they finally found the arrhythmia on the bottom slide, arising from the right coronary cusp of the aorta. And so they got the arrhythmia, they converted his AFib. That was fairly easy to do. And then once the procedure was done, they simply took the device out because the 4.0 is a percutaneous device. And this guy did absolutely fine. And I would argue that that could probably not have been done as well or as safely if at this was another case, a medical patient with a fairly uncommon form of cardiomyopathy called Takotsubo. This is a stress-induced cardiomyopathy, 67-year-old woman. She actually had this a couple of times over several years in the past for stress-induced reasons. And she came in with a heart rate in the 160s, diffuse ST segment elevation, and on the echo, if it were to run, it would show you a classic Takotsubo with the apical ballooning of the left ventricle. So they tried to improve her condition with medical therapy, and it was failing miserably. As they tried to slow her heart rate down, her blood pressure went down with it. So in that case, we ended up putting in the Impella, And again, it was another 4.0. This one was transfemoral at the time, so she wasn't somebody who was getting up and out of bed. But the Impella then allowed us to get rid of all these agents that were driving her blood pressure up, but also driving her heart rate up. So that allowed us to get rid of all those drugs, institute medical therapy, and it really had a dramatic response. I wish I could have shown these videos here. I don't think they're going to show. Well, maybe they will. Let me try it. I'm not tremendously optimistic here, but no, too bad. Well, the top one shows the apical ballooning of the left ventricle. The middle one shows the Impella across the aortic valve from the left ventricle into the aorta. And then just a few days later, as we got off of all these drugs and instituted good medical therapy, it only took a few days for her LV function to become absolutely normal. And we were able to get the device out literally, I think, just 2 days after instituting that. Now, none of that happens without this device. Shucks. Okay. That's not showing either. Okay, well, I have two cases. This was a recent case just about 2 months ago. This is a patient, young man, 49 years old, with severe biventricular failure, EF of 5 to 10%. He's got this unusual mutation called JAK2, which predisposes you to either bleeding too much or clotting too much. And for that reason, he was turned down for heart transplantation, but he was dying of heart failure. So we were thinking about putting in an implantable LVAD as a destination therapy or as an alternative to transplant. And we weren't really sure if we should commit ourselves to an implantable device, because if he's got this mutation, is that going to result in bleeding or clotting? So we thought we would do a sort of provocative trial with one of these percutaneous, albeit transaxillary LVADs that we had really nothing to lose there. So we had done that axillary approach, put in the 5.0 device, and much to our pleasure, that was the picture of the guy sitting in the chair. That's this case. So he ended up doing extremely well for over a month on the device. He didn't bleed and he didn't clot. So we felt fairly confident that he would tolerate an implantable LVAD. But then after discussing it a little bit further with the cardiac board, as you will, since he was in biventricular failure, it didn't make a lot of sense just to put an implantable LVAD, because we would still have right heart failure. So we sent him down to the transplant center and actually cut out the whole heart and put in a total heart as a internal biventricular device. And he's done extremely well with that. There's a picture of the BiVAD. And he's done very, very well with that. And he may actually turn into a transplant candidate. And this is our most recent case. This is a 37-year-old guy with a non-ischemic cardiomyopathy. Rapid AFib put him into acute decompensated state, EF of 10 to 15%. Now, this really turned fairly ugly very, very fast. So the first thing we did was put in the transaxillary Impella LVAD, and that's a CAT scan of that. So you can see on a CAT scan its position and how it looks. And worked extremely well, delivering 5 liters a minute, and his right heart actually held up beautifully. So he would be a wonderful candidate for an implantable LVAD. The problem was he got hypoxic, again from a pneumonia, and was hypercapnic and acidotic. So we actually added, we didn't take out the Impella, but we added a veno-venous ECMO circuit that took care of the hypoxia. And his ammonia is slowly improving, and as recently as this morning, it looks like we may be able to get off the ECMO part of it and then convert him to an implantable LVAD. So his outcomes to be determined. The point of this whole talk is to understand the collaboration that exists between the cardiologists, the cardiac surgeons, and to utilize them in specific ways for individualized patients, to collect the data, to understand what we're doing right, what we're doing wrong, use the technology that's state of the art to achieve the most favorable outcomes. Tomorrow, if you're here, you'll hear about a new device that is going to become FDA approved very, very soon. I have been monitoring this officially, the trial. The trial results are excellent, and we hope to have a percutaneous version of the LVAD in the form of an RVAD. Thank you very much. Oh, it's probably over there.
Yeah.
Yeah. Yeah, thank you very much. Thank you. And I want to thank my student for coming.
Just quickly, because we're a bit over time.
Use your role for a long-term use of the current device to help cardiac muscle regenerate.
Long-term meaning,
Yeah, because you mentioned like 2 months, I guess.
that's extremely rare. This is a short-term device, a week up to a month, and beyond that, you're very lucky if the device doesn't fail. They have to redesign it for longer-term use. It would be wonderful because it's so simple and small.
Okay, we'll move on to the third keynote speaker for this morning, Dr. Kate Denton from Monash University in Australia. Dr. Denton is a Senior Research Fellow of the National Health and Medical Research Council of Australia and Head of Cardiovascular and Renal Physiology at Monash University in Melbourne, in Australia, if in case you don't know where Melbourne is. Dr. Denton's goal is to improve cardiovascular health for men and women across their lifespan by building a strong interdisciplinary and translational research program around the integrative control of arterial pressure. Oops, you'll have to excuse me, Kate. So, with a strong emphasis on the contribution of the kidney. So we're going to direct a little bit off center, but it is good to bring this to this meeting because cardiorenal is an important area of research. Current research focuses upon sex differences in the role of the renin-angiotensin system in the regulation of blood pressure, the impact of a congenital reduction in renal mass on adult cardiovascular and renal health, and the effect of radiofrequency catheter ablation of the renal nerves on renal neurovascular function and arterial pressure in sheep models of chronic renal failure. Welcome, Dr. Kate Denton. That was a long sentence. Yes. Whereabouts were day one?
I think so. Certainly. So thank you. I'm delighted to be invited today and give you tell you about my research. That is probably a little bit off, different to what you're hearing, because I'm an integrative physiologist and perform basic science. So I'm going to be talking about the studies that have been looking at radiocatheter ablation of the renal nerves for the treatment of hypertension. So the, it doesn't work, does it? The initial trials, HTN1 and HTN2, demonstrated quite a profound reduction in arterial pressure following ablation of the renal nerves using this technique. And this was met with considerable excitement around the world and resulted in, but these studies were fairly poorly controlled, so a proof of principle. The latest trial, HTN3, has demonstrated that while safe, the outcome was that it didn't affect blood pressure better than placebo, which has dampened the enthusiasm to some extent for this technique. However, there are deficiencies with all of these studies. The initial studies were very poorly controlled, intentionally so because they're proof in principle. But for HTN3, perhaps there's great concern now that perhaps the denervation itself was not effective. And I'll talk a little bit about why they thought that later. So what I'm going to talk to you about is some of the studies in animal models that we've been doing looking at renal denervation and how it affects blood pressure in the long term. The first set of studies that I'll talk about are the ones that we've performed in conscious sheep over a period of time using a model of hypertensive chronic kidney disease. And then I'll talk a little bit about some rats, studies that we've been doing in rats, where we've been looking at how the nerves, when they grow, and they do regrow back into the kidney, how they affect function and how they perform. So the model of CKD that we've been using is one of fetal uninephrectomy. So these sheep are born with one kidney. After they've been mated, 120 days of gestation, of 150-day gestational period, we do fetal surgery and remove one kidney. These animals are then allowed to be born, and we follow them for long periods of time. So looking at this, I can't do it. The first study, we can see at 6 months of age in the sheep in black that only have one kidney, we can see that they have an increase in blood pressure and that this increase progresses with time. This increase in blood pressure is due to an increase in cardiac output initially at 6 months of age, due to a reduction in stroke, due to an increase in stroke volume, and therefore, and this is associated with an increase in blood volume. By 2 years of age, we see that the increase in cardiac output is no longer present, and that this the hypertension increase in blood pressure is due to an increase in total peripheral resistance in this model, which is reminiscent of human essential hypertension. In addition, of course, this is a model of CKD. These animals are born with one kidney. At birth, there's no effect on birth weight. The kidneys they have a reduced renal mass because you've removed half at birth as a fetus, but they don't have, that kidney has undergone considerable hypertrophy. So compared to a single kidney in an animal with two kidneys, the solitary kidney is now about 1.5 times the normal size of a normal kidney, and so there's been considerable compensatory growth. We also know that remaining kidney has had compensatory nephrogenesis. There are more nephrons in that single kidney compared to a single kidney animal with two kidneys. We also, in association with this, by 6 months of age, we've got a 30% reduction in glomerular filtration rate, and that this progresses, though not quite significantly, with age, renal function deteriorates. In association with this model of chronic kidney disease, don't touch the pad, keep my hands away, we see that there is marked cardiac impairment as well. They have ventricular hypertrophy, and when we do a Dubutramine challenge, we can see that there is an age-related decline in functional reserve, and that it is enhanced in the CKD model. We also know in this model, when at 5 years of age, when we've removed the vessels from these animals at autopsy, that when we look at the contractile response to perivascular nerve stimulation, that the responses of intrarenal arteries are enhanced, suggesting that there is an increase in sympathetic activity to these animals, because in response to phenylephrine, we don't see an enhanced contractile response, but when we stimulate the nerves, we see an enhanced response, contractile response, suggesting that either more noradrenaline is being released per stimulus, or that there's more nerves. So in this model, what we've done is looked at what happens with renal denervation. We've used the same catheter as used in the humans, the Simplicity Flex catheter, and we've used the prescribed protocol to cause the denervation. We have 4 groups of animals, a control or normotensive group of animals with intact renal nerves. They undergo a sham procedure. So the catheter is floated into the renal arteries, and the same methodology is applied, we just don't turn the machine on. Then we have a control with that group that undergoes renal denervation, and finally we have the 2 CKD groups, one that's intact and one that undergoes renal denervation. The protocol is that we float the catheter in, and then we apply 6 ablations in a circumferential method along the renal artery. In HTN-3, there is very real suggestion that this protocol was not followed, but up to 60% of the patients only received 1 ablation, and that in HTN3 that they were not effectively denervated. But in our study, we have followed the protocol very strictly, and every animal has received the 6 ablations on both renal arteries. And so what I'm going to be telling you about is the cohort of animals that are going through these studies, and these are a 5-year set of studies, but we've, don't try. We're in the very first stages now where we've performed at 6 months of age, we performed the baseline measurements. We've then at 10 months of age, the animals have undergone renal denervation, and then we've looked at 2 and 5 months following that denervation protocol to see what the effects are. So we're looking at baseline data that there are many studies that undergo in these sheep, and they're all conscious, so they're all awake. And we look at basal arterial pressure and renal function. And what I'm going to show you today is some studies looking at the effect of hemorrhage, where we're using the hemorrhage as a tool to show whether sympathetic activation is occurring or whether the kidneys are actually denervated, and also to see what the response is to hemorrhage and whether these animals that don't have renal nerves can respond adequately to a loss of blood. And so this is the blood pressure data and renal function over this period. So the before is at 6 months of age, and the 2 and 5 months following renal denervation. In the top panels, in black, we've got the control groups, and in red, the animals that had chronic kidney disease. Renal catheter ablation in the normotensive animals did not cause a significant change in arterial pressure. Not unexpected, it's been shown before in sheep. But in the CKD models, at 2 months of age, we see complete reversal of the increase in blood pressure, and that this is maintained out to 5 months of age, demonstrating that catheter ablation can treat the high blood pressure and that the effect is sustained. Importantly, in this model of CKD, we do not see an effect on on renal function. Glomerular filtration rate was entirely unaffected, and this was maintained. We don't see a greater fall in renal function in the ablated groups. We also see, we'll only have the 2-month data because the assays haven't been performed yet, is that with denervation we see a drop in plasma renin activity. Again, you'd expect this because the sympathetic nerves promote the reproduction of renin, and we see a decrease in both groups. It's greater in the normotensive groups, and this is because in this model of CKD, it's a low renin model of hypertension. So then we looked, as I said, at what happens during hemorrhage. So the hemorrhage is, of course, associated with a reflex activation of the sympathetic nerves, and so in the denervated animals, we expected that we would see attenuated ability to be able to recover blood pressure because we couldn't see the sympathetic response. And indeed, if we look at the top panels, the black are the normotensive animals, and in red, the hypertensive chronic kidney disease. If we look at blood pressure, in the open circles are the animals with intact blood pressure, and this is a 20% body weight of 20% blood volume hemorrhage, and it occurs over 15 minutes. We follow blood pressure throughout this time. You can see, of course, that blood pressure falls in that response to that in the animals with the intact nerves, and blood pressure returns fairly rapidly. In the denervated animals, however, blood pressure falls and remains low. We follow these animals for 3 hours, and with that period, there is no restoration of blood pressure. At the same time, in the normotensive animals, you can see that in the intact animals, plasma renin activity has been enhanced significantly. We would say that this is due to a reflex activation of the sympathetic nerves, because in denervated animals in black, you can see that plasma renin activity does not increase to anywhere near the same extent, and that this lack of increase in plasma renin activity is probably going some way to being the reason why blood pressure is not being restored in these animals. Similarly, we see that renal function is also affected. Glomerular filtration rates drops in response to the hemorrhage and is unable to recover to the same extent in the denervated group. We see similar effects in the chronic kidney disease, though there are differences in the response to hemorrhage between the intact animals as well, in part because it's a low renin model. They just can't produce the same amount of renin. But from these studies, what we can conclude is that 2 months after denervation, we can't activate the nerves reflexly, and that the response to hemorrhage is impaired. This data was finalised, the last few animals went through last week, and so this is the 5 months post-denervation. Again, you see some very similar responses, though in the chronic kidney disease, the effects are now greater, so suggesting that the effects are sustained and that we still do not see any response to stimulating the renal nerves at this point. So I've shown you that radiocatheter frequency ablation, so using exactly the same technique as we use in humans, this effect that we produce a sustained effect, decrease in renal blood pressure without affecting glomerular filtration rate, and that when we try to provoke a reflex activation of the renal nerves, these animals cannot respond, demonstrating that the denervation is ongoing and sustained. This is a little surprising because we know the renal nerves regrow. There is quite strong evidence that the nerves reinnervate the kidney with time. And so the next studies that I'm going to talk to you about were performed in rats. In this case, of course, the catheter is too large to be used in these animals, and so we've done surgical denervation, but it produces similar effects. And we've looked at how the nerves are affecting vascular function with time. So as I said, there's very strong evidence that the nerves regrow back into the kidney following denervation in both humans, dogs, and our own studies in sheep show that they regrow in the studies. And so what we've been looking at is if these nerves are present in the kidney, how are they affecting function? I've just shown you in response to hemorrhage that we see very little effective activation of these nerves, suggesting that they may be regrowing, but they're not behaving normally. So in these studies, these are Wistar rats. In the first 2 panels, you can see the sham animals. This is a flat mount of renal artery looking at glycoxylic staining of the nerve plexus on the vessel. You can see extensive neurovascular plexus on top of the vessel. Following renal denervation, we've managed to obliterate the nerves and they're not present. But by 12 weeks or 3 months after denervation, you can see that there's significant return of the nerves over the vessels. We've then taken blood vessels from these kidneys into lobar arteries and looked at the contractile responses in vitro. And what you can see is we've looked at 2, 12, and 35 or 9 months later. And in orange, you can see the normal response, contractile response to an increasing voltage stimulus, and in the immediately 2 weeks after denervation, you can see in blue that the response is entirely abolished. And though at 12 weeks of age, I've shown you that the nerves are returning, the responses are still very small. By 9 months, there appears to be further regrowth and effect. So the question is, so the nerves are there, but they're not able to produce a contractile response. So we wanted to look at this a little bit further, and it's known that within the kidney and most blood vessels that are sympathetically innervated, there are 2 types of neuroaffective junctions. There's close contacts where the nerve and the underlying smooth muscle, the basement membrane fuses and forms a neuroaffected junction, or there are non-contacting junctions where there's a much wider gap. You can determine whether close contacts or non-contacting synapses are being formed by the electrophysiological properties of the underlying smooth muscle. When a close contacting varicosity is being formed, you see excitatory junction potentials, which is, excitatory junction potentials. If no close contacts are being formed, those are absent. The excitatory junction potentials are induced by the release of ATP underlying the close contact. And so using electrophysiology, we looked at the responses of these vessels. And so here you can see the big response is the stimulus artifact, and this is the excitatory junction potential. Visually, you can see in the denervated animals that the excitatory junction potentials are reduced. And when we look at the different age times post-denervation, you can see that this is the normal excitatory junction responses in a kidney renal vessel, whereas denervation has markedly attenuated those responses. There is a degree of return and further return at 35 weeks, suggesting that the nerves are present, but they're not forming the same contacts. They're not able to produce the same effects because the nerves are not penetrating the tissues and innervating these smooth muscles to the same extent and resulting in lesser responses. And so one of the problems has been in with the effects of renal denervation is that all the animals early animal studies suggested that denervation was acutely up to a month effective, and then the responses would return. This is one of the studies that's quoted to suggest that the nerves regrow and the hypertension returns in SHR, and it suggests that while initially effective, it gradually returns and the hypertension is abolished. However, I think that this study was probably underpowered, and the method in which they used to measure blood pressure was tail cuff, and therefore they could not detect it because pretty much the difference in blood pressure here is 12 millimetres mercury, and it's 10 millimetres up mercury up here. So this is a hypertensive model of that we've also looked at. And so firstly, can show that 12 weeks post-denervation, the innervation density has returned, so the nerves are there. When we measure blood pressure in these animals with radiotelemetry, we can see that the effect is sustained and that blood pressure, the effect of denervation is long-term. And also, though unlike the CKD model in the sheep, it's not entirely brought back to normal, but is significantly reduced. As expected, we saw no effect on blood pressure in the the normotensive animals, as they have a relatively low level of sympathetic activity. Again, like I have previously shown you, the contractile response is attenuated in the Wistar ones. That was the data before. In the SHR, the response, in fact, has returned to a greater extent, but not completely, so there may be some degree of return of the innervation. Certainly, it's been suggested in the spontaneously hypertensive rat that there are neurotrophic factors that are enhance sympathetic growth, and so we may be seeing some of that here. But again, whoops, I've taken it out. If we look at the EJPs, no, I haven't, that we also see that they're not entirely returning. So though the nerves are there, they do not make the same contacts, and they are not able to have the same effect. So in summary, we've shown that renal denervation does cause a sustained fall in resting blood pressure in two different models, one of which used the same catheter, radiofrequency method and catheter that's used in humans, and that importantly, at least in the CKD model, that resting function was not renal function was not affected. We certainly have clear evidence that the nerves regrow, but we know that they don't function in the same way, that the close contacts are not being formed. Perhaps with greater periods of time, they may eventually re-establish. And there is the possibility that in the SHR, that the nerves may be growing back faster. And so in a hypertensive situation, the nerves may grow back to more rapidly. And finally, we've shown that in response to a physiological challenge, hemorrhage, that In the animals that were denervated, they could not mount an appropriate response to restore or maintain blood pressure, at least within 3 hours, and therefore suggesting that patients that have undergone catheter ablation may be more at risk from when subject to hemorrhage. Thank you.
Questions for Dr. Edmund?
In HTN, in the human trials, I suspect that the nerves are growing, and they are. We know from transplant patients the nerves regrow into the kidneys. They do. I think our studies show that when they grow, at least in, though I don't like to call 5 to 9 months short term, they don't function the same. They haven't established the same connections, and that's why the hypertension is the reduction in blood pressure is sustained. In HTN3, there was significant concerns that they had not effectively denervated in the first place. So the protocol for using these catheters is to float them in and provide 6 ablation places along the artery as you withdraw the catheter. In HTN3, 60% of patients only had 1 ablation applied. And that was put down to inexperience of the operators, a flaw in the study. No, I don't know. I think that initially these studies, and I know the people from the Baker Institute that were performing the initial pilot studies, HTN1 and HTN3, is that they were using these this technique in patients that were at considerable risk. They had resistant hypertension and they were uncontrolled, and they got ethical approval to trial it in those patients and produced some quite astounding results that were not maintained with HTN3. I believe that renal denervation does reduce blood pressure, and at least up until 5 months, which is as far as we've followed, does reduce blood pressure. It was always supposed in the original trials that it might be necessary to go back and repeat the ablation period protocol at treatment at periods in the future, but that has not had to happen yet.
Very interesting presentation. Just a question. Any doubts might be, any dreams regarding the implementation, the application of this technological form as applicable for preventing clinical implications?
I'm not too sure what you mean preventing clinical implications mean. And if I understand you, so one of the long-term outcomes of our study is that we know that these sheep have cardiac dysfunction. One of the things we'll be looking at into the future is whether reducing the blood pressure in the end prevents the cardiac dysfunction that we see, and whether it may be the dysfunction may be limited just by a short window. So if blood pressure increased at 9 months again, whether a short period delays of treatment delayed the outcome, or whether if we manage to if blood pressure does remain decreased for the whole period of the study, whether again that has effects, long-term effects for the heart. We hope to be able to perform both MRI and PET scan studies in these, and we want to look at neurotransmitter release into the heart and see whether that's not a mechanism via which this may be occurring.
Thank you.
Just a quick question. The hemorrhage response is very nice. It's suspected that was one of our concerns for the human studies. Do those patients need to have some precautions in terms of washing up from surgery?
So my studies, which suggest yes. I do not know of anyone who has either implicated any recommendations for that or had to look at that regard.
So in follow-up, do you think that physiological responses could return to normal after long?
I don't know. These are, so in, my studies are probably the longest that have ever followed how the nerves function as they regrow. I can only say that I can only wait and see whether it returns eventually. It may not. I don't know. Yeah.
While we're doing this, can you gather together for a photo? Just a second.
Yes, ladies and gentlemen, at this time, I'd like to invite you all to the front. We can gather together for one large group photo, and you can all share it with your colleagues back home as well in your institutions. Okay? So everybody, please come your way to the front right here. We'll gather all together side by side, shoulder to shoulder, nice and tight. Everybody smile nice and large. We'll be good to go. And then we'll have our coffee break and teas and good stuff, okay? Oh, if you don't want to, that's fine. I don't mind. Pick me up. What's that? Oh, I know that's me. Okay. Put this on mute for a second. There we go. Please help yourself. Make yourself comfortable.
Well done.
Okay. Congratulations. Beautiful study. Thank you.
1, 2, 2. I'm gonna pull up Frank V over here. Hang on. Okay, is this all the delegates? Everybody nice and... Everybody ready? Okay, he's going to take your photo. Everybody look at him. And count of 3. We'll take a few. 3, 2, 1. Big smile. Wave home. There you go. Get a few? Yeah. Everyone's looking at him, right? There you go. It looks great. Cool. All right. Got it? Thank you. All right, ladies and gentlemen. Oh, he's going to take one more here. You want to go? There you go. Room for one more. Yes. 15 minutes for your coffee and tea break and posters outside. You ready? One more. Here we go. Stand still. 3, 2, 1. There you go. Beautiful. All right, guys, let's go ahead and break. Thank you very much.
I'm drifting now. Did you notice I had to turn the page? I couldn't concentrate. I had to read it all out. So not quite there. I'm going to sleep now. It's about 12:30.
Okay. Let's do this. You gonna mute this? BNC? You want to use your laptop? You know what? See what's on the laptop? Yeah, and he'll take care of them. So I'll take care of them. You see it? You want to navigate through it, if you can pull it out, and we'll put it in the video one. Well, let's go. Let's see.
You can pull it out. Yeah, so I don't know how to use this. How to move it? I don't know the button. What's that? I don't even know how to. Okay. Where's the file at? Philadelphia. This one? Yes. That's correct. Okay. Need a.
It's on the loaded, I just want to make sure
It's in there. Okay, I'll take care of him and I'll get you. And we'll be ready to rock. Would you like to go through it? I just need to get one folder. Can I put it here on top?
So sad.
Did you?
Yes.
You want me to dim the lights back down or what?